So Dr. Stephen Grinspoon is a professor of medicine at Harvard Medical School, director of the Nutrition Obesity Research Center at Harvard, and Massachusetts General Hospital endowed chair in neuroendocrinology and metabolism. His research career has been focused on mechanisms of metabolic and cardiovascular complications in HIV. He's led numerous NIH R01 funded studies investigating people living with HIV for over 20 years and has numerous peer-reviewed publications. Work from his lab has suggested an increased rate of myocardial infarction or heart attacks in people living with HIV and highlights the relative contributions of traditional and non-traditional risk factors. Dr. Grinspoon is the co-principal investigator of the Clinical Coordinating Center for REPRIEVE, which he's about to present to us, chair of the REPRIEVE protocol, and chair of the Operational Leadership Committee. I will just make one remark, and it's not in my script, that in over 30 years as an academic physician myself, I think this trial that he is about to present is the most impactful in any field. So with that introduction, welcome, Dr. Grinspoon.
Thank you very much. Can you guys hear me? Yes, I hope so. Okay, I really appreciate it, Anne, and organizers of this course. Let me just share my slides for 1 second. And can you see these, I hope? Yeah.
Yes, Dr. Grinspoon, yes, we can see your slides. Thank you.
Excellent. Thank you so much. Let me just do one thing here. Okay, so it's a pleasure to be able to present the results of the REPRIEVE trial. And again, thanks for the invitation. I'm sorry I'm not able to be there in person. But today I'll be discussing the rationale, results, and clinical implications of our trial for cardiovascular prevention in people with HIV. My disclosures and funding are shown here. So a couple of objectives I'd like to make sure we get through today. One is to understand the rates of cardiovascular disease among people with HIV and key risk factors contributing to development in this population. Also to understand the rationale of our trial and its primary findings and the impact for the care of people with HIV globally. And to understand the unique phenotype of cardiovascular disease in people with HIV, novel mechanisms and the effects of statins on plaque and key biomarkers, and really what else the trial has taught us about this disease in this population and lessons for other populations as well. So just to remind you, why do we initiate REPRIEVE? Well, cardiovascular disease is known to be increased in the HIV population. And this is a slide showing hazard ratios, effect sizes for myocardial infarction or coronary heart disease in large epidemiological studies. And anything above the blue line suggests an increased risk of myocardial infarction among people with HIV. And you can see there's a consistency here in these very large trials. And in the most recent of them, that was a global meta-analysis a few years ago now, the result was entirely consistent with over a 50% increase in this risk. And in the VAX cohort by Matt Freiberg, the hazard ratio was 1.48, and critically, this was adjusting for Framingham risk score and other comorbidities, which is a hint that this risk was beyond traditional risk factors among the HIV population. And there are other data, much more recent data, suggesting this trend is continuing. These are data from Kerry Altoff in PLOS Med 2023. I have an arrow showing that myocardial infarction rates are increasing among people with HIV, along with dyslipidemia and other comorbidities. And this is true among many of the subgroups of people with living with HIV, as you can see here. So this myocardial infarction and heart disease are a major comorbidity, as is cancer and other things, but we focus REPRIEVE, of course, on coronary artery disease and coronary heart disease. I also want to go back to one of the studies I pointed to in that overall slide about epidemiology. This is our study at Mass General led by Gene Tryon, and one of the first studies to show that there was an increased risk of myocardial infarction. In our study, we showed it to be a 75% increased risk in our large research patient database cohort. But importantly, we looked at diseases that are associated with cardiovascular disease, including hypertension, diabetes, and dyslipidemia. And in our cohort, we saw significant increases in all of these diseases, kind of the troika of cardiovascular disease, um, over non-HIV infected patients, the darker blue versus the lighter blue bars here on the right. But what's really important is that when we did modeling accounting for those three conditions, they did contribute to the increased risk, but they contributed about 25% of the excess risk. So, and this is a really important hint that we're going to come back to when I talk about REPRIEVE. So I just want to be clear. It's not saying that these factors don't matter. It's saying that there's probably something else. Now, we did not control for smoking here, and I'm going to get back to another slide in which we do control for that later in REPRIEVE, and I'll show you those data. But this was an early hint of things to come among people with HIV. So then, if it's not just traditional cardiovascular risk, what then is it? What's contributing to this? So we know, of course, HIV is a viral infection, and it's associated with immune dysfunction, we know that, and simultaneously with residual immune activation, even with effective ART. And really both may contribute to excess cardiovascular disease in people with HIV, and particularly this excess low-grade residual immune activation, even among people on antiretroviral therapy, and I'm going to get back to that as well, is a really important contributing factor. And in this particular slide in a study by Carolyn Sabin, she's plotting the nadir CD4 count versus myocardial infarction and the duration of immune suppression. And you can see that there is a strong relationship both in the lower the nadir CD4, the higher the rate of myocardial infarction, and the longer the duration of immunosuppression, the higher the rate of myocardial infarction, consistent with the hypothesis I'm laying out for you. I'd also like to spend a moment to discuss the unique phenotype of coronary artery disease in people with HIV to lay the groundwork for REPRIEVE. So the phenotype of coronary artery disease in people with HIV is characterized by, and this is unique to this population, I believe, arterial inflammation and vulnerable plaque, even among young people with HIV with low traditional risk scores. And it's seen in association with immune activation, as I was suggesting. And this is a study we published in JAMA a couple of years ago. And you can see here that we compared people with HIV to Framingham risk match controls, exact same risk score, and non-HIV controls with known cardiovascular disease. And what we measured here is the aortic target to background ratio. And this is a measure of FDG PET avidity, which is a marker of inflammation. As FDG gets caught in glycolysis or increased turnover, and it's thought to represent inflammation, this high glucose turnover state. And you can see here that there was a significant increase in the aortic inflammation target to background ratio. And the inflammation was as high as it was in non-HIV controls with known cardiovascular disease. So this is a pretty interesting finding, and it was the first direct evidence of arterial inflammation consistent with this hypothesis in this group of patients. And you can see here a control patient on the left and an HIV patient with HIV on the right. And you can see in the ascending aorta the significant increase in arterial inflammation shown by FDG PET. So this is an important study showing this directly. There's also a significant and interesting phenotype of plaque among people with HIV. And shown here are some images from CT angiography. And just as a bit of a primer, the riskiest plaque, um, maybe in contrast to what you might think, is not calcified plaque, but actually non-calcified plaque. And non-calcified plaque is high-risk, vulnerable plaque that's more likely to rupture, whereas calcified plaque, even though it's associated with heart disease, is really plaque that's sort of tombed over, and it's associated more with traditional risk factors like smoking. But non-calcified plaque is uniquely present in young people with HIV, and you can see here that you can't see it. It's clear here. It's off to the side. It's called positively remodeled. It's eccentric to the lumen, fatty, and this creates risk because there's significant myocardium at risk. It's not like the vessel is slowly choked off in the traditional sense with myocardium at risk, but the lesion is off to the side, not causing much problem, not causing angina, not causing symptoms. But when it ruptures, because it has a thin cap fibroatheroma, this surface is very thin and full of inflamed cells. When it ruptures, it causes a major problem. So people with HIV have two of these classical characteristics of high-risk plaque: low attenuation or fatty non-calcified plaque and positively remodeled plaque. And we showed this statistically in a study we did a number of years ago now, where we compared people with HIV and non, and you can see that they had more of these features. We think this uniquely contributes, and I'll show you some very new data at the end suggesting this is indeed the case. I also want to speak a moment about antiretroviral therapy. Of course, antiretroviral therapy is critical. We know it's critical to enhancing and prolonging the lives of people with HIV, and it's been revolutionary. But from the perspective of inflammation, residual immune activation, and cardiovascular disease, putting someone on effective antiretroviral therapy is probably not enough, in the sense of there is residual immune activation. And we showed this in a study in which we compared naive patients with HIV who went on tripla at that time. And you can see here that we're looking at indices of T cell activation. Here's percent activated CD8 positive T cells. And there's a significant decrease over time with the addition of antiretroviral therapy, but still a much higher level of activation compared to control. And when we looked at FDG PET, these juicy lymph nodes in the naive patient went right down. As you can see here, they're no longer visible in the bottom panel here, but the aortic inflammation persisted. And indeed, studies have quantified this relationship, looking at IL-6, for example, as a marker of residual immune activation. And there is a significant relationship between increasing levels of IL-6 and quartiles of events among people with HIV. So we really believe that this residual immune activation is associated and strongly predictive of events in this population. So this leads to a paradigm that we had in our mind when we started REPRIEVE, which is that there is initial immune dysfunction, but there is persistent viral replication in T cells and monocytes. There's also microbial translocation leading to T cell activation, monocyte activation, residual risk, and activation of inflammasome and other pathways, which contributes to this collateral damage, if you will, of inflamed organs, including the endothelial surface of the arteries. So there are a number of challenges that we encountered in designing REPRIEVE, and these challenges include identifying patients with subclinical disease. If the disease is not clinically apparent, how do you pick your population to prevent the disease in, particularly when traditional risk factors may not be all that predictive? That was interesting, and I'll tell you our logic in that regard. And we wanted to develop an intervention that addresses both traditional and immune-related risk factors, of course, which would be the holy grail in this population. And finally, we wanted and needed to develop a strategy that's safe and effective. So we hypothesized that a statin strategy would prevent cardiovascular disease, even in people with HIV with low to moderate traditional risk. It would have pleiotropic effects beyond LDL lowering, addressing the unique phenotype of inflamed, low attenuation vulnerable plaque. And this design was unique in that primary prevention studies in non-HIV populations have focused on populations with much higher traditional predicted risk than REPRIEVE did. And that's what's really unique about REPRIEVE, and I'll tell you in a moment. But the baseline predicted traditional risk in REPRIEVE was only a level of 4.6% risk of cardiovascular disease in the upcoming 10 years, whereas most other studies have a much higher risk, 7, 9, 10% risk, even higher. So that's what was really unique. We were really going after a population with low traditional risk. And we know that statins will lower LDL. We knew that at the time, but there's also was emerging data which has been shown to in many studies now that statins uniquely target excess immune activation. And we know that statins reduce lipid oxidation and activation of the NLRP3 inflammasome, and then also potentially affecting plaque inflammation. And we know that statins reduce indices of monocyte and T cell activation. And this cartoon here on the left shows that statins have an effect to decrease lipid oxidation, an important part of atheromal and foam cell formation. They reduce endocytosis, blocking the NLRP3 inflammasome, and have a strong effect on MYD88, also contributing to that inhibition of the inflammasome. And when you look in studies directly comparing placebo versus a statin in people with HIV, you see a strong effect to reduce markers of inflammation. Here, soluble CD14, which is a measure of the soluble receptor of lipopolysaccharide, and a measure of gut leakage and microbiome translocation. So that led us to the development of REPRIEVE, which was, as I mentioned, a randomized trial to prevent vascular events in people with HIV. This was a pivotal trial. It was performed in 110 sites across the United States, Canada, Spain, Thailand, Brazil, South Africa, Zimbabwe, Uganda, Botswana, Peru, India, and Haiti. Yeah, we opened for recruitment in 2015, and we closed recruitment in 2019. And the trial was stopped early in 2023 by our Data Safety Monitoring Board for efficacy, and I'll tell you that in a moment. The design of REPRIEVE is fairly straightforward in the sense of that we chose asymptomatic people with HIV who had no known disease, all of whom were taking antiretroviral therapy, and they had to have low to moderate traditional risk, and that was for equipoise. If someone has a very, very high traditional risk score, they should go on a statin, and it's not so much primary prevention anymore. So we enrolled 7,769 participants. We assigned them to placebo or pitavastatin, and I'll mention why pitavastatin in a moment. And then we followed them over time. Turns out our average duration of follow-up was about 5 years, 5.5 years. And our primary endpoint was MACE, major adverse cardiovascular events. And this included endpoints of CVD death, MI, unstable angina, TIA or stroke, arterial revascularization or peripheral artery disease. We also included death of an unknown etiology here, but we did a sensitivity analysis taking it out, same result. We had some significant other significant endpoints, including predictors, individual components, effects on inflammation, and of course, safety, looking at comorbidities, including diabetes, infections, and cancer. So our sites are shown here. We had sites all over the globe, as I mentioned, in North America, South America, Africa, Europe, and Asia. And you can see that we enrolled approximately 15% of our population from sub-Saharan Africa, about 7% from South Asia, about 7% from East Asia, 18% from Latin America, and about half from high-income regions in North America and Europe. So truly a very diverse and global population. So why do we pick pitavastatin? Because pitavastatin is minimally metabolized by CYP3A with good effects on lipids and inflammatory pathways. And pitavastatin is a moderate intensity statin at 4 milligrams a day. It has no known interactions with PIs or any antiretroviral therapy. At the time, the data suggested it would have no effects on glucose. So I'm going to talk more about that. And compared to other ones, which do have some effects with protease inhibitors, but no effects with others, it was the choice that we made. Interestingly, it's metabolized by glucuronidation, so only minimally metabolized by CYP3A, and which is why it has very limited interactions with other medications. The study population was defined based on an inclusion criteria that is listed on the left: documented HIV, on stable antiretroviral therapy, age between 40 to 75, no known cardiovascular disease, and a hybrid score, which included a risk score and an LDL level of cholesterol. So for example, if your risk score was very low, less than 7.5, we tolerated an LDL up to 190. If you had a higher risk score between 7.5 and 10, we tolerated less of an LDL, less than 160. And if you had the highest risk score that we allowed in, 10 to 15%, we only tolerated an LDL of less than 130. So as you can imagine, our LDL was not particularly elevated in this trial, which makes it even more interesting, and I'll show you that data. We excluded patients who were using currently statins or gemfibrozol or PCSK9 inhibitors or had decompensated cirrhosis. So here are the primary results of REPRIEVE. Among 7,769 participants age 50, so relatively young, with a median ASCVD risk of only 4.5%, which is really quite low. And this is a risk I would suggest that most physicians would do absolutely nothing about if a patient came into their office with this calculated risk. And this is what's interesting about REPRIEVE, how it's changed guidelines, and I'll get to that. The average LDL was 108. So this is not a particularly high-risk group on the one hand. On the other hand, they had a lot of events, and the study showed a significant 35%, in the final data it was 36% reduction versus placebo, and first MACE or any death was a 21% reduction versus placebo. So this is a very, very significant result, particularly that it's occurring in such a young population having disease that's not predicted by traditional risk. And 35%, I want to put that in the context of some other studies that were published in the England Journal in other realms to great fanfare, including semaglutide and cardiovascular outcomes in obesity without diabetes. Great study, 20% reduction in MACE. And another study, anti-inflammatory therapy with canakinumab for atherosclerotic disease, 15% reduction in MACE. So our result was really quite significant and larger than these other very, very well-known studies. So let's do a deeper dive into some of the components. As I mentioned, there was 36% reduction in first primary MACE. When we looked at hard MACE, which is taking out peripheral artery disease and looking at the hardest, the most significant components, stroke, myocardial infarction, or death, the effect was even larger. It was a 41% reduction. And this was true in all our supporting analyses. And when you look at the individual components, We are underpowered for these, but if you just look at the point estimates here, you can see a pretty consistent effect across all primary components of the MACE. Peripheral artery disease is way over here, but there were a few events. No one on pitavastatin had peripheral artery disease versus a few on placebo. But in general, and that's even more impressive, but in general, the point estimates are all very consistent. A couple things that caught our eye. First of all, if you look at these first two lines here, similar effects in stroke and myocardial infarction, but the number of strokes was almost identical to the number of myocardial infarctions. So stroke is an understudied and undertreated area for people with HIV, but the good news is that in this study, pitavastatin nicely prevented strokes as well as myocardial infarction. And then we looked at treatment modifiers and effects in key subgroups. So our overall risk is shown here in orange, but I want to draw your attention to a few things. The efficacy was similar whether you had a high LDL or a low LDL, which is really important. So the efficacy was independent of your LDL level, even though this is an LDL lowering drug. Pretty cool. The other thing is there was no major difference between males and females, which is really important. So we had enough power to suggest that the point estimates were almost identical in males and females. I'll get back to a few other points along the way, but these were some of the main points that we took away from this. More than 80% in both groups remained in follow-up. The LDL reduction, which is pretty incredible considering that this drug is available, off study to anyone who wanted to go in, but our patients stayed true to the study and remained in study in great numbers. And this is true even despite the fact that we had to deal with a global pandemic of COVID right in the middle of the study, which I can talk about. LDL was reduced by 30%. You can see here the purplish violin plots versus the green ones. And this is exactly what you'd expect from a moderate risk statin. And you can see, so the baseline levels went from about 107, 108 to about 70, remained in the lowish 70s, which is a pretty good LDL for primary prevention. All our MACE events were adjudicated versus COVID, and only one was definitively related to COVID. So our participants remained in the study and took their medicine and were largely not affected by COVID. They had a good vaccination rate and remained healthy in that regard. So in terms of safety, the DSMB concluded that there were no unanticipated safety concerns. Only 1% versus 0.5% pitava versus placebo withdrew for muscle-related symptomatology. Diabetes rates were slightly increased in the pitava group, 5.3%, but were 4% in the placebo group. So it was only essentially a 1% difference. And this is consistent with other studies. And importantly, even among the group who got diabetes, there was a protective effect of statins in this group. In fact, there was a 50% reduction in MACE among diabetics in the pitava versus placebo group. And there was no effect on grade 3 ALT or rhabdomyolysis in the study. This is an important slide, and these are data taken from the CTTC collaborative published in The Lancet. And this was a study that plotted the mean LDL difference between treatment groups in these major statin studies versus the efficacy in terms of reduction in MACE rate. And you can see that plotted along these lines, there's a regression, and the difference in LDL in millimoles was 0.8 between our statin and placebo arm. You go up to the regression line, you go over, and we should have had a 17% reduction in MACE. But indeed, we had ultimately a 36 or 35% reduction in MACE. And this reduction was like twice the level that we might have anticipated from LDL lowering alone. So I want to be clear, I'm not saying that LDL lowering doesn't matter. It matters a lot and probably got us a huge effect here. But there's something probably beyond the LDL lowering that allows us to be up here, way off the curve. And that was also suggested by the fact that the result was independent of the baseline LDL. Now let's talk about number needed to treat, which is a concept that physicians, I think, are pretty familiar with. How many do you need to treat to prevent one MACE event? So overall, in the study, we needed to treat 100 people to prevent one MACE, which is actually pretty good when you consider how young and relatively healthy the population is. And in fact, as the risk score goes up, the number needed to treat goes down. And so you can use the risk score, even though it's not overall the only thing that contributes to disease. It is helpful as a guide in the sense of the number needed to treat. So the number needed to treat in patients between 5 and 10 was 53. And this is clearly a zone in which people are not really put on statins. Over 10% it's recommended. In here, the number needed to treat was 34. The number needed to treat was even actually quite reasonable in the lowest risk populations up here. Just to give you some perspective, aspirin and antihypertensive have number needed to treat for primary prevention in the 200 or 300s. So REPRIEVE was pretty effective and clearly had a very reasonable number needed to treat, especially in those above 5%, and even in those less. So given all this, the Department of Health and Human Services and AHA, ACC, and last week, the IAS came out with the same guidelines. They've recommended to change the guidelines for primary prevention in people with HIV. So the traditional risk algorithm is shown here. Those with more than 20% should all be on a statin, and those between 5 and 20 should have a discussion. Most physicians would probably treat people more than 10%, but clearly between 5 and 10%, this borderline risk zone, there was lack of clarity. Now, in the prior guidelines, HIV was listed as a inflammatory disease and a risk factor, but no one knew whether statins would be effective in this group. And so based on the data of REPRIEVE, the number needed to treat I just showed you, these groups, including the IAS, have now recommended that any person with HIV with a more than 5% predicted risk should get pitavastatin. This is an A1 recommendation at 4 milligrams per day. Recognizing that it wouldn't be available for everyone, although it is pretty widely available and now off patent and super cheap, the A2 recommendation was that if that wasn't available, rosuvastatin at 10 milligrams a day or atorva at 20. And that's because these other drugs don't have huge interactions with antiretroviral therapy. Interestingly, they even made a C1 recommendation of statins for those less than 5%, recognizing that everyone will age into a risk more than 5% over time because the traditional risk score includes age and it goes up with increasing age. And so many people say, well, if I'm at a 3 or 4%, I'm going to age into 5% and there's relatively little risk. Maybe I'll start earlier to prevent that. And that is one thing we can talk about in the question and answer period if you're interested. I'll also talk about underprediction with these traditional scores in a moment. Oh, here I am. Okay, so we looked at the predictive factors of the risk scores, and we compared the observed to expected ratio of events. So this was presented at CROI last year. It's going to be in press in a major journal in the next couple months. And overall, at the study, the top line level, there was congruence between the observed and expected rates of events. But when you looked at subgroups, particularly in high income areas for females or Black or African American participants, there was significant underestimation. And by that, I mean the observed events on the Y were greater than the predicted events on the X. Okay, and so that means significant underestimation. So among Females and Black or African Americans, quite significant. And in fact, this was to a degree that you could probably multiply the traditional risk score by a kind of a correction factor, um, which is approximately around 2 with some variance for different subgroups. And you can read about that in a future publication. And that may be worth doing, because if the risk score is showing 2.5 in an African American woman, for example, but that real risk score based on this is in the recalibration, which we were able to do, is more like 5 or 6, then that person would cross the line into an A1 recommendation. So stay tuned for this paper, which will be coming out shortly. We also looked at modifiable risk factors on first MACE. And in this particular study, we showed that traditional risk factors were associated. So for example, Black or African race, and this is all accounting for statin. So Black or African American race was significantly related. Participants from South Asia had a much higher risk in high income in South Asia than in Latin America and Sub-Saharan Africa, which is quite interesting. And in all these analyses, the unadjusted is red and the blue is adjusted for everything else. Smoking is obviously a big risk factor. Family history of cardiovascular disease. But interestingly, one of the more interesting data points in our study, you can see this at the bottom here, is that among patients with detectable HIV RNA, their risk was significantly higher even after adjustment for all other factors. So in a group on ART, we had about 10% that had very minimally elevated viral load, but the signal was larger in that group, which is really an interesting observation, strongly suggesting that it is important to put your patients on effective continuous antiretroviral therapy. So these are the risk factors that were associated. Interestingly, there was no effect of female sex after adjustment, suggesting that female sex, unlike in the general population, is itself a much stronger risk factor for cardiovascular disease in people with HIV. In terms of diabetes, as I mentioned, a slight increased risk. But if you look at whether the patients had diabetes or metabolic syndrome, whether they had obesity or metabolic syndrome, the risk of diabetes was much larger in those who had obesity or metabolic syndrome. Obesity is here, metabolic syndrome, prediabetes is up here. And so this suggested to us a very important paradigm. On the left is pitavastatin and the right is placebo. The curves look almost very, very similar. So yes, there's a slight increased risk with pitavastatin. That's kind of a side point. The bigger point here is that the risk of diabetes among people with HIV is quite minimal if you don't have prediabetes or you're not obese. It's only seen really among patients with prediabetes, obesity, metabolic syndrome. And that's true whether you're on a statin or on placebo. And that's really important, and also suggests that our clinicians should focus on these risk factors if they want to treat or prevent diabetes from occurring in this population. Now, let's take a minute to discuss the mechanistic substudy, which I mentioned looked at CT angiography. And our primary endpoint for the mechanistic study was change in non-calcified plaque, as I went over with you, how I thought in the field feels that it's higher risk plaque. And we saw a significant reduction in non-calcified plaque and a significant decline in the progression. So in the pitavastatin group, only 37% progressed over 2 years, which is what the duration of follow-up was in the sub-study. But in the placebo group, 50% progressed. In the pitavastatin group, 53% regressed versus 41% in the placebo. So pitavastatin, and I think statin therapy in general, is quite useful to reduce non-calcified plaque in this population. It was also useful to reduce markers of inflammation, including Lp(PLA2), oxidized LDL, and high sensitivity CRP. We had a modest effect on that as well. So inflammatory markers improved. We also showed some very novel mechanistic pathways. Standing out here is P-CoLC. This is a marker of collagen formation. So statins actually increase this, and this is thought to actually lead to more fibrous plaque, more calcified plaque, if you will, which is less vulnerable and at risk for rupture. And statins have a well-known effect to increase calcium score, which is not a risk factor, but is actually thought to be quite protective. And so REPRIEVE showed us for the first time a potential mechanism through this gene and enzyme P-CoLC, which increases mature collagen formation. There's a lot to dig into here. We have a lot of work to do, but we showed through proteomic analysis that statins also improve networks of integrin adhesion, viral interaction with cytokines, lipid metabolism, and complement coagulation activation cascade, as shown in these other proteins. The change in P-CoLC modified 84 or mediated 84% of the reduction in non-calcified plaque. Other biomarkers were not as significant, so that's quite interesting. And as I mentioned, this change in P-CoLC was associated with an increase in calcified plaque volume, but at the same time, a reduction in non-calcified plaque volume, which we think will make the plaque safer. These results are going to be published in another journal next week. Stay tuned for them, but they were presented at CROI last year. I'll skip this, but this is basically a summary of those data with respect to P-CoLC, whereas the statins increase P-CoLC and reduce LDL, and it's the increase in P-CoLC, not necessarily the reduction in LDL, which is so significantly related to plaque stabilization, so a non-LDL mechanism. Getting back to our original hypothesis of is non-calcified plaque dangerous? Yes, it is. We looked at MACE in the sub-study, and indeed, if the patients had non-calcified plaque, which about 40 to 45% did, those patients were at about a 2.6-fold increased risk for MACE. And it looks as if, very preliminarily, that statins may work better among those with non-calcified plaque. And we need to follow that up with further data. So in summary, cardiovascular risk is increased among people with HIV despite young age and only low to moderate traditional cardiovascular risk. Among a population of HIV patients, 40 to 75 on ART with low to moderate risk and really a normal range LDL, treatment with a statin strategy is well tolerated, effective, and will prevent MACE with a large risk reduction of 36% and a very reasonable number needed to treat. And this effect is greater than that explained from LDL reduction alone, and we've started to explore different pathways which may help to explain this. Further work will be needed to understand how to utilize the pool cohort risk equation in subpopulations of HIV in whom it underpredicts, which I mentioned. Further work is needed to assess the clinical implications on MACE of effects of key inflammatory and immune pathways. We do have some very, very preliminary data that will be presented at CROI suggesting there is a residual risk or relationship of these inflammatory pathways to MACE in people with HIV. Stay tuned for that presentation at CROI. And now we've shown novel effects to promote collagen formation, which may help stabilize plaque. So I wanted to thank you for listening, our participants, our site teams. I know Eisenhower here was one of our teams, and thank you so much to Anne and her team for that. Our investigators and our funders. This was primarily an NIH-funded study with some help from Kala Pharmaceuticals. So thank you all for your attention. I'm happy to address any questions if there are any. Thank you.
So I'm back, Dr. Grinspoon. This is Dr. Stapleton. I'm going to actually first ask a question, and this is for our online participants because I was part of a hybrid meeting by accident right after that airline shutdown over the summer, and we discovered quickly that if we don't have someone with a microphone, no one online can hear any of the questions. So my first question, I promised a bunch of patients I would ask you this question, and the nutshell of it is it really important to be on 20 milligrams of atorvastatin versus 10? So why am I asking you this question? So as you mentioned, we were privileged to be one of the site participants. And so as soon as the study was closed for, as I explained to patients, really ethical reasons, when you find out and your safety monitoring board finds out that there's this huge difference and you can't continue ethically without telling everyone, I'm now telling you as a patient that you need a statin to reduce inflammation. And even though our patients are largely on statins, if they have traditional risk factors and have a higher score on the 10-year risk equation. In my particular case, these people are, I think most people's panels here in the desert are around age 65 on average. They are largely Medicare patients, very well educated. They read the literature, not just Dr. Google, but they read primary literature, and they really want to know, why do you want me to be taking this drug? So I started trying to sell a statin that was on their Medicare formularies, generally atorvastatin or rosuvastatin, and unfortunately often not pitavastatin, even if we fight for it. So I started selling this to people before the guidelines came out. And when they came out, basically just about everybody needs to be on 20 milligrams. So do you have data to suggest that they should be on 20 versus 10? And because, of course, people's LDLs were pretty good to start with. That's why they were not on the statin to begin with. And they went down a lot because they will on 10 milligrams of atorvastatin. So again, my question is, do we need to give them 20?
I don't have data to know that because you need a head-to-head comparison, but I think it's a good question, and I'll sort of reframe it. If they're only going to agree to 10 versus not being on a statin, I'd readily agree to them being on 10. Because I think if their LDL is low and you're monitoring and they can get down to a level of 70 on 10, that's probably pretty good. I don't know exactly, whether 10 or 20 will be better on inflammatory pathways, and I think that's pending. So all I can say is that there's kind of a dose equivalency of 20 to 4 milligrams of pitavastatin, but that doesn't mean that I can prove to you that 10 won't work well. And I think getting them on a statin, any statin is based on REPRIEVE is better than having them not on a statin. Probably it's okay, but I can't necessarily prove that. The thing that I do think is true is that, if starting at a high dose of a statin results in intolerance, which it doesn't often do, but rarely does, then starting low and going slow is absolutely fine because it's a long haul. If they're 60 or 65, they're going to be on this for hopefully 20 years. And that's what's happened in the general population. It's safe for long-term use. So better to get them on it and go slow to get there than not. So I think I would monitor their LDL. I think based on some of the papers we might have coming out, you could look at CRP as well and see if that's nice and low, but stay tuned for that. So I think it's probably the right instinct, though I can't 100% prove to you that it is equal, if that makes sense.
Thank you. Great answer. So I'm going to actually take any other questions and repeat them as best I can here from the microphone so the online participants can hear. So other questions? So Dr. Del Rosario is asking, are there any other inflammatory markers or other markers that we should track aside from CRP?
I think CRP is the main one at the moment. We're looking at that in the entire study. What we're measuring in the whole study, because what I showed you before was just in the sub-study. So here's what we're measuring, and here's what we'll be able to report on to you. CRP, IL-6, oxidized LDL, LP-LA, LP-PLA2, ApoB100, and troponin. Troponin, which you may not be used to, other than, oh boy, someone's having an MI in the ER, did they get a troponin level, has actually been one of the more interesting biomarkers. And I say that I only have data from the sub-study, but we just published it in JACC Advances. What we showed is that 60% of the REPRIEVE population, sub-study population, had a detectable troponin despite no disease whatsoever, no symptoms. And that troponin strongly predicted plaque. And I can tell you that it predicts MACE too. So right now, I can't, hasn't been published yet, and will be presented at CROI. But this is sort of hot off the press, but I think in addition to CRP, we might be recommending some other markers of some subclinical myocardial injury, which I'm not sure why that's occurring in this group, but they may be predictive of MACE. So stay tuned in that regard. Right now, I can just say CRP or IL-6, but I beg you to let us do a little more work on that and get back to you. It's a phenomenal question, and everyone wants to know that question. Are there biomarkers that predict MACE in people with HIV that we can use to augment the pool cohort risk equation? And we will absolutely address that question. We just need a little more time to measure the biomarkers in 7,500 people times 2. It's a lot of work. Thank you for a great question.
Thank you. Other questions? Yes.
How hard should we push for pitavastatin over the other statin?
How hard should we push for pitavastatin over the other statins?
I mean, the study was done with pitavastatin, so it officially relates to pitavastatin. I don't personally think there's anything magical about pitavastatin other than it's very, very well tolerated. And we had really no one that had any interaction with antiretroviral therapy. If you think about that, across 12 countries, 8,000 people, that's pretty impressive. Our diabetes rates were very low. Rosuvastatin, high dose rosuvastatin, for example, is associated with higher diabetes rates in the general population. So ironically, because pitavastatin is a relatively modest and moderate intensity statin, that may have allowed it to be very well tolerated, not associated with diabetes, etc., but still quite anti-inflammatory. If it's not on your formulary and it's a pain in the neck to get it, I think atorvastatin or even low dose rosuvastatin are absolutely fine. I know that, and I have nothing to say, I'm not getting any money from Cow or anything, but I know that it is off patent. So I think it should be available generically and very cheap, along with the other ones, but that may take some time to wind its way through the system in that regard. For the moment, whatever is on your formulary, if the other two, through the recommendations, are on your formulary, I'd feel very, very comfortable with you using those.
Okay. Other questions? Go ahead.
For the controllers that they included in the cohort, we've been treating them with ARVs just to kind of address the higher risk for cardiovascular risks. So we'd be including them for the treatment recommendations.
So the issue of elite controls is raised, that we've been treating them with ARVs in order to reduce these types of complications. Should statins be, you're asking, should statins be included in that as well, or, okay. So did you have elite controllers in the trial? I don't recall that being brought out.
We didn't specifically look for that. It's a good, because we don't have like prior viral load history. So we'd have to go back into the charts and see. But I think that that's a good point, that, there are blips even among elite controllers. And we have shown in prior studies that elite controllers do have some degree of residual immune activation. So I would say that's a very good question that person asked. I don't know who it was, but um, uh, that's probably, I probably would say that based on our theories and efficacy data, we're showing that elite controllers, despite them having very little risk of AIDS-related things, should probably be on a statin for the very same reasons that our study was efficacious. Now, we didn't specifically study elite controllers, and you could argue, well, maybe their degree of residual immune activation is less, but we have shown and others have shown they do have residual immune activation. So based on that premise, I think that's quite reasonable. And again, because this is a relatively cheap, inexpensive, and safe therapy, I think there's a very low risk of doing that. But it's a great question and a very provocative one. Thank you. I think the answer is yes.
Hey, I think we have something else. Yes, Jeff.
Hi, Steve. So this was a stunning accomplishment, getting nearly 8,000 people in a study and funding it. And, the ACDG has a long history of cohorts like ALERT, the HALO, and so forth being discontinued. And as the population gets older, there could be a huge value in continuing this in some way or form. Are there any efforts to do that? Do you see that as something worth doing?
So I'll repeat that for the online people and a little bit shorter. Jeff Taylor is asking the question, since ACGG, and I will mention also, I've been part of EDIC, EURO-EDIC study, which is a continuation of a type 1 diabetes study that's been going on for decades. These are incredibly valuable cohorts, and which is Jeff is asking, is there any plan to do that at your site or at NIH, as NIH,
Yeah. So let me just a quick answer. That's a great question. So first of all, I really would like to emphasize that the NIH, in a very collaborative way, this was funded through the National Heart, Lung, and Blood Institute, despite the fact that it was a study of people with HIV. And the NIAID contributed in kind all the monitoring expenses and drug distribution money. And then, so it was a collaborative effort that was, let's say, 85% funded by NIH and 15% funded by industry who donated the drug. It was a wonderful collaborative effort across multiple institutes, and really a tribute to NIH that they agreed to do this. And a lot of times the NIH gets grief, but here they really stepped up. Now we're trying to get them to step up again to follow this cohort along. And I think we can talk to you, people like you, Jeff, and others, to try and make that happen. I think if they did do that, it could become the Framingham sort of cohort of people with HIV. There's a long history of studies in this regard, that there's sort of a memory of statin effect, and even if you go off it, you still have some residual effect. We hope everyone will stay on it based on guidelines, but we can look at that. We can look at duration. We can have a much longer follow-up time, because as you saw, those curves were diverging, and we had to stop the study short after only 5 years of follow-up. We were supposed to go another 2 years, actually, and then the curves would have been even more separated. We would have had more power. But so I do think that's a really good idea. We could glean data on the sex effects and race effects, and long-term comorbidities and long-term effects on inflammation. So we're on it. We've made a proposal to NIH, and hopefully they'll agree, but I have to see. They spent a lot of money the first time. I don't know if they're going to spend the same amount of money the second time, but we'll try. Thank you.
Yeah, we're very excited and hope you do get the funding. And patients are also interested in knowing if other measures of inflammation, in terms of even clinical readouts, end up going down over time. And that's not something you can answer in 5 years.
Yeah.
The disparity between LDL lowering and the endpoints is something almost everyone can understand, and why I'm trying to get them to accept if they're not already on one. Right. And I think one hope I hold out is that we don't know for sure, but we've been hand-waving about inflammation all these years and have really done little about it other than giving ARVs. This could be an intervention that would make a difference in other realms aside from cardiovascular and cerebrovascular risk.
I might add one last thing. you know, REPRIEVE was highly effective. You can't argue with a 36% reduction. But it may be the case that there are inflammatory pathways which relate to MACE, which were, you know, modified less by statins in our study, so that could suggest that certainly statin might be a base of therapy, but maybe there are other things to add to statins. Maybe I'm just making the anti-IL. I don't know. So we need to look at our data very carefully to look at this because, you know, even though 36% is really, really pretty good, it's not perfect. And so there might be add-on strategies. They'll be probably more expensive and riskier and whatnot, because statins is always going to be the base. And I'm glad we started there, but I think that's a whole nother area we're looking at.
Thanks again for joining us. We're really thrilled to have you and glad to know you're going to be continuing your work in this area.
Thank you very much. I really appreciate being here. Thank you for the invitation.